You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
Okay, we had our disclosures, case study. This is TM, 57-year-old Asian woman. Here she is, TM. You take a kind of a weight history in patients that have obesity because she seeks assistance with weight loss. She's had slow weight gain throughout adulthood, failed multiple diet plans. She's a busy mom and receptionist, ends up eating fast foods due to time constraint, hypertension, treated with thiazide, hydrochlorothiazide, complains of knee pain, increasing shortness of breath with exertion over the past 4 months, family history of cardiometabolic disease. Her physical exam, her BMI is 37, blood pressure 140/84, trace of edema in both ankles. Labs, she has fasting glucose 121, hemoglobin A1C 6.3, so prediabetes. The dyslipidemia of insulin resistance there, high triglycerides, low HDL. LDL is 105, and her non-HDL is 138. Which is, I think, a little bit elevated over the LDL level there. Liver functions, normal, everything, no albuminuria, EKG. Knee film shows some joint space narrowing. So if you develop a problem list, I think this is what mine would be. Adiposity-based chronic disease with an anthropometric component, class 2 obesity, with a clinical component, multiple weight-related complications. Some of those are as follows: the hypertension, one medication with blood pressure not a target, osteoarthritis, both these, increasing shortness of breath, causation not established, prediabetes, metabolic syndrome with dyslipidemia. So that's my problem list. So which of the following assessments is potentially harmful, or which of your findings on initial intake are the potentially most harmful in the short term and warrants more pressing evaluation? Yeah, bingo. I think if we're looking at all of these things that are important, but what is going to be most harmful in the short term, which could kill her sooner rather than later, it's that symptom report of shortness of breath with exertion. It seems to be bothering her. It's increasing over time with less and less exertion. So that's something I agree with the audience. That's something we really need to pay attention to sooner rather than later, not to exclude all these other things. Okay. So which of the following is the worst choice? If we're developing a differential diagnosis for this shortness of breath, which is the most knuckleheaded choice in the differential diagnosis, A through F? Yes, I agree with this. We don't want to ascribe it to just obesity. This is what happens. So, our patient has a BMI of 35. Of course, they can't breathe. They can't walk. They just need to lose weight. We're missing patients with serious problems. We're missing patients with HFpEF in particular, which, as we know, is not uncommon. And we saw what the longevity was with this complication, and we have ways to treat it. So I think that's the most knuckleheaded choice out of that list. Okay, so it just kind of reiterates here her shortness of breath, and the trace edema that she has. So what's the reasonable next step for evaluation? I think that's right. You saw it's a test we can order. It's a blood test. It's within our scope. It's the next thing to do. We saw that in the guidelines, American Heart Association, other professional societies. I think that is the next best test. And here I'm going to go through these. I unpacked these slides that I've already shown you. ESC, get a BNP. American Heart Association, get a PNP, if not an echocardiography. I showed you the data on semaglutide improving symptoms and functionality. In these recommended guidelines, all these societies mention SGLT2 inhibitors, but now we know we can add GLP-1 receptors to the list. And I wanted to make a point here on this slide I showed you before with a combination of data from all of these phase 3 trials, SELECT, FLOW, STEP, HFpEF trials, and you're seeing worsening heart failure events in the top right, and that includes both HFrEF and HFpEF. And what else? A number of these patients were already on SGLT2 inhibitors when they were put on the semaglutide, and there's an additive benefit. It's not like one or the other. It's like if you use both of those, you get additive and increased benefits in terms of the impact on these outcome measures, worsening heart failure, et cetera.
The one thing that they really show is not so much cardiovascular death reduction, but rehospitalization. And I don't know if you remember a couple of years ago, several years ago, one of the biggest metrics that the government was making hospitals look at was rehospitalization for heart failure within 1 to 6 months. And it is a very morbid and very expensive process. And this is a phenomenal addition to that.
Yeah. That's one of the leading causes of increase of high healthcare costs. I mean, you know, these companies are doing kind of health economic analyses in terms of the impact of these medicines. So good point. Tirzepatide, we also show improved not only symptoms but heart outcomes like CV death and heart failure events and hospitalizations.
Can I add one thing to that real quickly?
Yes, sir.
Finerenone, which we'll talk about tomorrow, diabetic kidney disease, a non-steroidal MRA, and we will go through the difference a little bit between the spiroeplerenone versus finerenone. Finerenone is probably going to get a 1 classification for all forms of heart failure, but certainly for HFpEF, because a recent trial showed very favorable outcomes in patients with an ejection fraction, I believe it was, of 40% or greater. So not in HFrEF, but in HFpEF. So it's going to be approved, and I think insurance is going to start paying for it. And we really don't know if it's different than spironolactone, but it's spironolactone in the TopCat heart failure trial with HFpEF just missed showing a benefit. So if you're a purist, you would go maybe with finerenone in this case. More on that. But I just want you to know there is another drug that is going to be with the SGLT2s, the GLP-1s, and probably sema and tirzepatide are going to get the lead there, and maybe finerenone, I think, also.
Good. Yeah, that's a drug of the future, I think, with expanding.
I mean,
But you're going to talk more about that on...
We're going to talk about that more tomorrow.
Yeah.
And we're going to talk more tomorrow.
Right. Okay. Lipid question about TM. So you know she has the prediabetes, metabolic syndrome. She has the dyslipidemia, has hypertension. What is the most appropriate goal and best treatment combination for addressing her dyslipidemia? Okay. I mean, some of these answers are not wrong. I think even the panelists here might disagree on some of these. My choice is less than 70 with a high-intensity statin. Why? Because I think this patient has prediabetes, which several professional societies consider a diabetes equivalent in terms of our aggressiveness and preventing cardiovascular disease. I mentioned to you that this is a state of this accelerated atherosclerosis. There are, it's not only prediabetes, but there's other risk factors present. So diabetes plus risk factors are prediabetes plus risk factors, additional risk factors. It puts you in a very high-risk group where the target cholesterol is less than 70. High-intensity statins. Dr. Cornier, Marc showed some algorithms with moderate-intensity statins. I don't even know why we use moderate-intensity statins if it's well-tolerated. When the lower the cholesterol is, the better in almost everybody. So 1F is the same cholesterol target with the low-intensity statin. Why? I mean, we want the lower cholesterol, the better. I think based on some of the studies that I showed you earlier. So I think E is the right choice. You guys,
Yeah, I mean, I think the problem with C, obviously, we like the Mediterranean diet. We like the idea of having her lose weight. Those are important things. But it's missing one, the statin. The statin is indicated regardless of LDL. And so whether it's high intensity or moderate intensity, we could fight about that one. I want her on a statin, period, plus those other things. I like the less than 70. I would do the 10-year risk score, see what her 10-year risk, but I guarantee it's going to be, it may not be that high because she's a young woman, so that's the problem with that 10-year risk score.
Yeah.
But she's got multiple risk factors, and I certainly would put at the very least moderate, but I would agree that a high intensity in this person with LDL less than
but
70.
D was the most common, and I think many doctors would agree with that. I mean, I don't think that's a wrong answer. If you have to consider prediabetes to be a diabetes equivalent to get to E, and
Right.
that's just my predilection. So I think I would give credit for D
But
as well.
C is concerning because I'm assuming that you all wouldn't have used a statin. And I just don't understand the reluctance. I mean, I think there should be, I'll just tell you, if I was going to get a test, I probably would get a high sensitivity CRP in the pre-diabetic. I don't need it. I'm going to treat him with a statin. But, I've got to have a reason not to use a statin in a patient these days. That's my approach. They are so safe. They are so effective. I think they're the greatest pharmacologic agent that we've had since the 80s. I mean, bar none. But,
But I think it's also wrong not to have diet and caloric deficit. That as part of your treatment plan, right? You just put everybody on a statin, put everybody on Ozempic. We need the healthy living. We need weight loss. Those are all important.
statins, they're not costing.
Well, I understand, but I think the best answer would be a combination of these. I think because I think they need to be on a healthy diet too.
Yeah, I'm gonna move on here. So, just to increase risk, I've showed you these studies before.
See, the Jupiter trial was a primary prevention, the one before this that you showed, right?
Yeah,
They had to have a high sensitivity CRP over 2 to get into this because they had a decent LDL, less than 100 to get in, 40 to 100. And the high sensitivity CRP drove a lot of the benefit. Mm-hmm. So, it's an inflammatory disease, and prediabetes is an inflammatory disease as part of the metabolic syndrome. And I'm not a big lab person, but that's why I would have a low threshold for using a statin. And personally, I think atorvastatin 40 is a very good starting dose of a statin.
Resuva 20.
Okay.
More effective.
but those are all high intensity. So,
Okay.
let me just keep moving. Okay, and then we talked about ApoB here. So her LDL cholesterol was 105, and her non-HDL cholesterol was 138. So she's not too far off target there, I think.
Right.
But those are the ApoB goals. It's a very high that we'd want an ApoB of less than 80. So anyway, we should go into the next. Well, I think this is the last question about this patient. So it's the hypertension issue. She was 140 over 84 with all these other risk factors. She tells you she was put on lisinopril some time ago, but she had coughing. What's the most appropriate change in treatment for hypertension you might recommend to her? Okay, adlosartan. How come another thing came up?
No, that was part.
Either one. I give credit for either one. Yeah. You could take advantage of an obesity medication, which is going to lower the blood pressure to get the extra kick you need. Or I think adding losartan, an ARB, not an ACE, to cause more coughing, like an allopril might, would be appropriate too. Jan, would you add finerenone at this stage?
Oh, no.
Stage?
Oh,
Okay.
no.
All right.
No way.
Elodipine would be reasonable, or no? Because
What's that?
And we want the ACE, a RAS blockade on this patient, don't we? Or
We would use the RAS blockade. We don't know if she has proteinuria, but as a combination, absolutely. And I'd just like you to leave here thinking about starting someone on a single fixed dose combination drug. A word about losartan. So she was on 100. And losartan at 100 is not always a long-acting 24-hour drug. In fact, in the insert, go and look at it. Merck had to put in there that in some patients, the drug will not last 24 hours. So 50 BID may be better than 100. If you're doing out-of-office blood pressures and getting evening and morning blood pressures, that will help you because the evening blood pressure will be controlled, but when they first wake up in the morning, if they're taking the drug in the morning, they're not controlled. That's when you go to the BID. So I like 125 of Hyzar. It's generic, it's free, and you take a half a tablet in the morning, a half a tablet in the evening, 50, 12.5, 50, 12.5, 6 half-lives. They're not urinating during the night. Don't worry about that. If they are, they got a prostate problem or they're not taking the medicine like you'd like them. And I think that's a very effective way to treat this hypertension.
How about telmisartan instead?
What's that?
A different.
Oh, I love telmisartan much more than losartan. Telmisartan is a very long-acting, evidence-based ARB. It's a workhorse. Yeah, I love telmisartan.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.